There we go. So, right, the valves could either be too stiff or they're too leaky. Their job is to allow blood to flow in one direction. So either of these problems either makes it harder to flow out or it makes it more likely to backflow. We're not going to get into cardiomyopathies. These are a group of diseases or disorders that affect the cardiomyocytes themselves. So mitochondrial dysfunction can affect it, and people have inherited mitochondrial diseases. You can get infective carditis, and that, if it infects the cardiac myocytes, that can lead to cardiomyopathy. So this is just a group of diseases that cause dysfunction of the cardiac cells themselves. And then we have congenital diseases, and we're not going to get into that too, that there's a lot of congenital heart disease. Mostly they involve the malformation of the heart. So either the vessels are twisted, they're connected in the wrong way, or the ventricles or the atrium in development are open to each other so that blood flows freely between the right and the left atrium, and it flows freely between the left and the right ventricles. Anybody want to guess why? Why does a developing fetus, why would it have that opening?
It doesn't use those organs to purify the blood, right? It uses the mother organ.
Because it doesn't have, the lungs are not developed and they're not being used. So we're basically allowing the heart to bypass the lung circulation. You do still get some blood going out to the lungs, but to decrease the amount of pressure that goes of the blood that goes to the lungs in a developing fetus, you have those holes in the heart so that the blood comes in through the right atrium and it basically just goes right back out the left ventricle. Only a fraction of the blood gets circulated into the lungs. Because of course the fetus is not breathing, the oxygenation comes from placental blood exchange. Excellent. Yes?
What is it called when a baby's born still? Because I know my sister was born with that, but she still had
The whole, it's called atrial septal defect if it's between the atrium, or ventricular septal defect if it's between the ventricles. And it's not uncommon. I would venture at least one of us has a small ASD, atrial septal defect. And they're pretty easy to repair now. You can just go in and put a little patch over it and repair it. There's actually some research, some interesting research, that there may be a link between a atrial septal defect, persistent atrial septal defect, and migraines. Most of us don't have our heart imaged, and so we wouldn't know that we have this because oftentimes it doesn't cause too many symptoms if it's small. All right, so those are the major kinds of heart disease. We're just going to focus on these two. Here's a world map, just to put into perspective the importance of ischemic heart disease. So this is showing now this is not death from ischemic heart disease. This is the disability adjusted life years. So right here, this is DALY. So disability adjusted life years. And this is a metric that was designed to try to look at the lost productivity associated with the disease, because often you can look at death, but that only tells you the end point. If somebody has ischemic heart disease for the last 10 years of their life, and it limits their ability to get out and do something, it limits their ability to work, it limits their ability to help take care of their family members, then that is another additional burden that is put on society. So DALYs is a way to try to quantify that lost productivity associated with a certain disease rather than just the death or mortality associated with it. Is anybody surprised looking at this? I think we have in the top here is men, and down here is women. I was a little bit surprised. I thought the U.S. would be among the highest countries with ischemic heart disease. But it's actually Russia and some of the North African countries. Yeah.
How do they control for economic variances between countries?
They're not. They're just trying to quantify how much, and it's not in terms of, I think they translate it into US dollars, but it's really this person is not able to contribute to society, or this person's only contributing 50% of what we would expect a healthy 60-year-old to do. So it's not meant to, or it's naturally contained within how they calculate it, the economic variable, because the control is a normal person in that society at that age.
In the society there?
In this society, yeah, so you're comparing. So if you're looking in Russia, a normal, healthy 60-year-old in Russia versus a person with ischemic heart disease at 60. Yeah.
So could it be because the U.S. maybe has better ways of controlling the ischemic heart disease? That's why we're technically considered this yellow area where
Yep.
Russia doesn't have these medications, doesn't have these therapies, and therefore someone who's 60 with ischemic heart disease is way more dependable on the Russian government and therefore less able to help than someone who's 60 in the U.S.
Right. I think you're exactly right. So she said maybe the reason the U.S. isn't higher is not because of our incidence is any different, but because we have better treatments. So somebody who has a first heart attack, if we can get them to the hospital, we can actually put in a stent and try to prevent a full transmural infarct. So they may not have quite as much effect of that disease. Or somebody who comes in with angina, we're going to put them on some preventative medications so that we try to prevent that first heart attack. Yes?
Why are women things like that affected by this?
So again, this is, you mean just because there's more countries that have red?
No, just if you look from men to women, like South America and Africa, the women.
Probably because women are more important. Right? Wasn't yesterday International Women's Day? Yeah. Maybe, I don't know, that's a good question.
Are they more susceptible to heart disease?
Women are not more susceptible to heart disease. By age 60 or 65, women and men have about equal rates. Men tend to get it, or manifestations of it, earlier. And the way that they experience heart disease is a little bit different. Women tend to have diastolic heart failure, men tend to have systolic heart failure, but the incidence is roughly the same. Yeah.
Actually, if you look at the scale of the graph on the men, the green is from 200 to like, what is that?
Oh, good eyes.
61 to 300. So the scale is way skewed. So
Why would they use different scales?
They're just comparing, they just want you to compare countries to countries.
like you could put the yellow for the women's over the men. Many more of the green countries with men would have been yellow.
Yeah, that's great eyes.
Do you think they would even use it?
Okay, but the basic point of this was to show you there's a lot of people out there with heart disease, and it affects not just their quantity of life, but their quality of life. Okay, so here's a little fun review for us. Think back to anatomy and physiology, and I want you to work with a partner to figure out, see if you remember these terms. We have stroke volume, cardiac output, preload and afterload, and end diastolic volume. What is stroke volume?
The amount of blood pumped out every time you have a heartbeat.
Yeah, right. Every time the ventricle contracts, the amount of blood that's pushed out of the heart. So the stroke volume, we can refer to it either on the right side or the left side. Usually we're talking about the left ventricle, so the amount of the volume of blood that's pumped with every heartbeat out of the left ventricle. So what does that depend on? Which of these terms? Right, end diastolic volume. So the end diastolic volume is, of course, the volume in the heart at the end of diastole. What is diastole? Relaxation, right? So when the ventricle is fully relaxed, so that's its maximum volume. And at the beginning of systole, which is ventricular contraction, so the end diastolic volume is going to determine our stroke volume. Depends on end diastolic volume and the contractility of that ventricle. What about cardiac output? What are the terms that go into determining cardiac output? Yes. Yep. Stroke volume and heart rate. So cardiac output is the amount of blood the heart puts out. And that depends on how fast the heart is beating and the stroke volume. And of course, as heart rate goes up, does stroke volume go up or go down? It goes down, right? Because if the heart doesn't have as much time to relax, it doesn't have as much time to fill in between heartbeats. Preload and afterload, what are those terms? Did you learn those in AMP? Yes?
Preload is essentially the same as end diastolic volume, and afterload is how much is left after systole.
Right. So preload is the same as end diastolic volume. It's how much load, how much blood is in the ventricle before you start systole. And then afterload is how much blood is left after the heart has fully contracted, so after systole. All right, good refresher. Does everybody feel comfortable with these terms? It's especially important when we go into heart failure. All right, it's quiz day. So this was a question at the end of last lecture. We didn't quite get there, but it absolutely pertains to coronary artery disease, which is the #1 cause of ischemic heart failure. So here's a coronary vessel. What's the arrow pointing to? Plaque? Yep. What part of the plaque? The necrotic core, absolutely. So looking here at this coronary vessel, here's the lumen, adventitia around the outside. Here's the media right here. But you can see that most of this vessel has atherosclerosis built up in the intima. This may be a little bit normal, but even that is kind of thick. So here's the cap of our plaque, and then we have the necrotic core down here. And you'll notice that where the plaque is the thickest, the media kind of gets squished out. So the media is thin over here. So one of the reasons that atherosclerosis is dangerous, other than causing thrombosis, blockage of the vessel, was that it could rupture. So it can cause an aneurysm, it can cause that medial wall to get very thin and weak, and it can rupture out and you get bleeding. But in this case, the coronary lumen is normally about that thick, and in this case, it's about that wide. So the diameter of that is decreased in half. So what's the effect on flow? Yeah.
I would say it would be 4 times normal flow.
So you think 4 times the normal flow?
Well, yeah, it would decrease by 4 times.
Decreased by 4 times. So 1/4 or 1/16? 1/4. So it does decrease, And it decreases by a lot. It actually decreases by 1/16. This was more just a fun trivia. You don't have to do that kind of calculation. But you guys remember, I think it was Bernoulli's equation from physics? Basically, flow is inversely proportional to diameter, or the radius to the 4th power. Anyways, the point of this is not the exact number, but the point is that flow is decreased by a lot. So even 50% stenosis or 50% blockage, you're really slowing down blood flow through that vessel. So if you remember the carotid ultrasound picture we saw, where the blood is going really fast and then it has to slow down to get past that atherosclerosis, that's what's going on in every vessel that has it, including coronary vessels. So let's talk about ischemic heart disease. I already told you that in 90% of cases, the cause is coronary artery disease, which is atherosclerosis. So you get plaque buildup in the coronary arteries. But there are some other causes. What are some other causes of ischemic heart disease? They were on the quiz, so I know some of you know these. Oxygen deficiency, right? So maybe a person is anemic. Anemia. Or maybe they have inhaled too much carbon monoxide, so CO poisoning. Carbon monoxide displaces carbon dioxide. It has a higher affinity on hemoglobin than carbon dioxide. So if you're exposed to carbon monoxide, it's going to displace not carbon dioxide. It's going to displace oxygen on hemoglobin. It has a higher affinity than oxygen. Anemia. What's anemia? Low iron, which means low red blood cells. Yeah. So anemia is actually a low red blood cells. The hematocrit is the measure. Hematocrit is the percentage of your blood that's taken up by red blood cells. So you can't make red blood cells unless you have enough iron to make hemoglobin. And if you don't have enough red blood cells carrying oxygen through their blood, then you won't get enough oxygen to the heart. You won't get enough oxygen to the rest of the body as well. But it can cause, because the heart is so metabolically active, you'll maybe feel the effects on the heart sooner than you would on other organs. What else? Increased heart rate, right? So something like hyperthyroidism. And if any of you have any thyroid problems, you know if you take too much thyroid medication, you get kind of jittery, and your heart starts to beat really fast. You get palpitations. So hyperthyroidism increases the metabolic demand of the heart by increasing heart rate. And if you can't meet that metabolic demand, then you get ischemia, reduced blood flow. All right, so basically you guys have already told me the mechanisms, the pathophysiology here. So you either have increased metabolic demand, decrease oxygen supply in the blood, or decrease blood flow. So the atherosclerosis will cause decreased blood flow. And then we talked about the increased metabolic demand. Left ventricular hypertrophy is another increased metabolic demand. So somebody who has high blood pressure and their ventricle is contracting against increased pressure over and over and over again, that ventricle adapts by hypertrophy. But now, in doing so, it's increased its own metabolic demand. Now you have more contractile units within each myocyte, not more myocytes, but more contractile units, and so you require more oxygen and more glucose to meet that supply. So clinically, oh yes?
Blood pressure for the galaxies, like doing shock.
So shock, low blood pressure, yes. So decreased blood flow to the heart. Most of the time that will be coronary atherosclerosis. You just can't get the blood through the vessels. But in a person who's in shock, either gunshot wound and they're bleeding out, or maybe they've have sepsis and they have systemic inflammation, that low blood volume will affect all of the organs, but the heart is one of those end organs that won't get enough blood to meet its demands. So yes. And clinically, yes, question?
What was LVH again?
Left ventricular hypertrophy. Clinically, with ischemic heart disease, you basically have 3 clinical outcomes, or kind of 2, maybe 3. We'll call them, so you have angina, which is pain in the heart, but it's also often referred pain. So you've heard left arm pain is a bad sign. So angina can be experienced as like really bad chest pressure or a shooting pain down the left arm. Any of those can be called angina. So heart pain, heart pressure, chest pressure, or shooting pain down the left arm. Sometimes even some people will feel it up in their jaw. A heart attack. So coronary artery disease or atherosclerosis is called the silent killer because a lot of people don't experience any symptoms. A lot of people don't experience angina because they don't have enough ischemia to produce the pain until they have a major event. Maybe that atherosclerotic plaque ruptures, they get a thrombus, blocking blood flow totally, and their very first symptom that they have anything wrong is a heart attack. And then some people, either because of a heart attack or a minor heart attack, or just reduced blood flow from chronic ischemia, will experience arrhythmias. Arrhythmia is an electrical abnormality in the heart. A lot of people with chronic heart disease will have atrial fibrillation. So that's an electrical abnormality. Most people who die of a heart attack die of ventricular fibrillation. So if your atria isn't contracting in a coordinated fashion, it's not that big of a deal. A lot of blood will continue to passively flow from the atrium into the ventricle, so that's okay. If your ventricle experiences electric discordance, meaning that all the myocytes aren't contracting at the same time, then you have a problem because your cardiac output is going to be severely reduced. You're not able to generate enough contractility. You can't maintain stroke volume, cardiac output goes down. So arrhythmias can happen independent, just the myocytes or the contracting cells, they don't have enough ATP to work properly, and it causes damage, or a heart attack can also lead to arrhythmias. So those are the main clinical symptoms with ischemic heart disease. So let's look at a little bit more. Yes?
Oh, I was just wondering, why is it specifically the left side that you get pain when you have angina?
Oh, it has to do with the nerves as they cross in the spinal cord or in the cervical spine. I can't remember exactly how it is, but referred pain is generally when your nerves carrying your pain signals come back into the spinal cord, and they synapse on and go up to your brain to tell you what's going on. Those connections can sometimes be a little bit off. And so the pain signal from your heart going into your spinal cord, and it relays up to the brain, and your brain thinks it came from the arm, even though it actually came from the heart, because of that, the connection of the nerves within the spinal cord.
I remember reading somewhere that men have more pain in the left arm, or women have more like right in the middle of their shoulder.
Yes, so absolutely. Women tend to experience angina more as pressure, like central pressure right here, or between their shoulder blades, some pain between their shoulder blades. Men tend to get the classic jaw and left-sided arm pain. I don't know why. I know that's going to be your next question. Yeah, I don't know why that is, but definitely clinically very important to recognize that. So we classify angina in 3 different ways. Stable angina is when you don't experience chest pain unless you're exercising or exerting yourself. So this stable means pain with exertion. So the best treatment for this is rest. That's counterproductive if lifestyle is the cause of the coronary artery disease. But we can also give nitroglycerin. What do you think nitroglycerin's mechanism of action is? Yeah. Oh, good guess. No, it doesn't block the pain. But we could, yes. It is. It's a vasodilator. So nitro causes those coronary arteries to vasodilate. Unstable angina is pain at rest. So now, it's harder to predict when a person's going to experience pain. Sometimes people will wake up at night with heart pain. Or they wake up in the morning and they feel just this tightness, this pain in their chest. And they haven't exerted themselves or anything yet. So if you start to get pain at rest, it's unstable angina, and that's a really bad sign. Typically, we think of stable angina. You start to feel pain with about 70% stenosis of your coronary vessels. Unstable angina is when you have blockage of about 90%. And you can imagine if the vast majority of the lumen is occluded by atherosclerosis, it doesn't take much. A little bit of a spasm could close that off completely. Or a small thrombosis can cause that to close off. So that's probably what is going on with people with unstable angina. It gets blocked a little bit and then it opens up, either spasm or a small thrombus. And then we have this other Prince-Metal angina. And this one is really unpredictable. And it's thought to be caused by vasospasm. And it can actually occur in people who don't even have coronary artery disease. For some reason, some people's coronary vessels can become very susceptible to hormonal influences, adrenergic influences like norepinephrine or epinephrine. So they can get coronary vessel spasms related to, and that can cause angina, but in the absence of coronary artery disease. So this is vasospasm. And very often, people with angina who don't change major things about their lifestyle are going to go on to have a heart attack. That's why one of the things we tend to do is treat people who have angina with drugs like beta blockers or blood pressure lowering drugs to prevent them from going on to have a heart attack. So myocardial infarction is where you have a complete ischemia, complete loss of blood flow to a region of the heart. And we've already talked about some of the mechanisms of this, but by far it happens with thrombosis. So if you have some plaque built up in your arteries, we talked only a little bit about it, but the plaque it can have a really stable, firm cap over it. Or sometimes there's a natural process of remodeling, or the more necrotic core you get built up in there, that cap can become thinned. When the cap over the atherosclerotic plaque is thinned, it is at high risk of rupture. And as soon as it ruptures, that necrotic material that leaks out causes thrombosis. It activates platelets, it activates endothelial cells, and it activates the coagulation factors to instantly cause a clot. So if that happens in your coronary vessel, and in this image right here, this is from your book, they're showing a clot formed right here. The other way you could get a clot in your vessels, which is less common but still happens, is let's say somebody's had chronic heart disease and they've developed atrial fibrillation as a result of that. Atrial fibrillation allows the blood to pool a little bit in the atria. Pooling blood is bad. You never want your blood to sit still because, as you've probably experienced, when you see just pooling blood, it over time will clot. Just the natural decay of the coagulation factors will activate the clotting cascade. So you can get these what are called mural thrombi. Those are clots that form on the wall of the atrium. And then every once in a while, a little piece of that might break off. The coronary vessels are the first vessels that come off from the aorta. And so that clot that comes from the heart can go into the coronary vessels and block the coronary vessels. That's called an embolism. So you can get that as well. But whatever the mechanism, whatever happens to cause the total occlusion, you already can predict what happens, right? We've already talked about the mechanisms going forward. So you have ischemia, loss of blood flow to the area. What does that do to the heart cells? Think back to cellular injury. Right. So you're going to have reduced ATP production. As soon as you have reduced ATP, if you remember when we learned about actin and myosin, ATP is actually required to relax. So when you have the contraction, then you use ATP to relax the cell back, and mediated by calcium. So these calcium pumps are driven by ATP. So immediately, as soon as you stop producing ATP, and that happens within seconds of occlusion, you can't produce any more ATP, the cells contract and they can't relax. So that myocardium is called stunned, and it's basically held in a contracted state. Now, that stunning is still reversible injury. But if that occlusion stays there for longer than 20 minutes, your cells can withstand this contraction for about 20 minutes. After that point of time, greater than 20 minutes, you go into irreversible injury. Mm-hmm.
So we had a volunteer at the hospital. We had a case. A guy came to use airback from he had a heart attack on top of a snowball.
Oh no.
Back in, and when he was passed out on the ground, no one was doing CPR, and he said that basically killed him because his heart was now stiff and there was no way to repair it. Because the
Well, no, actually, it's mostly because what CPR does is it forces your heart to push blood out to the body. So he may have died, you could go into a coma. If your brain doesn't get blood for 20 minutes, you're going to go into a coma. So if the heart attack is massive enough that your heart stops beating, or it generates an arrhythmia causing you to go into ventricular fibrillation, you're not pushing enough blood out. And so CPR pumps the ventricle manually to get enough blood to the rest of the body, mostly the brain, that's the important part, and the coronary vessels to keep the rest of the heart alive until you can get to the hospital and reperfuse that site. So that's the point. That's what CPR is doing.
Because they mentioned that it was because the heart was stiff is why they couldn't do anything for that.
Yeah, and it might have just, it's really hard in situations like that where if they had a massive heart attack and it was at the top of Snowball and you couldn't get them into a reperfusion lab within an hour, he would probably die even if people were doing CPR because enough myocardium would be lost from that. But yeah, I'm not sure about the stiff heart probably is because of this contraction, and if it's longer than 20 to 40 minutes, that's irreversible. But I don't know, that's actually a good question. Would CPR kind of force some of that permanent contraction to loosen up a little bit? I don't know. I like that thought. All right, so we've gotten to irreversible injury. So door to balloon time, or door to stent time, door to reperfusion, you'll hear all of these terms because the goal is to open that vessel as quick as possible because time is muscle, is what they say, right? Time is heart muscle. So after 20 minutes, your cells start dying, and they die in a relatively orderly fashion. So to think about the pattern of cell death, we have to think about the zone of perfusion. So if the clot is happening right here, this blood vessel is supplying a part of the heart wall called the zone of perfusion. That means that zone is getting all of its oxygen from the red blood cells that come through this vessel right here. Over here, this part is getting from another vessel or another tributary of that vessel. So the zone of perfusion is what's going to be affected by that ischemia. And the zone of necrosis goes from the farthest away tissue towards the closest. So here you see that this endocardium, subendocardium, the endocardium is the inner lining of the heart. So the subendocardium is the heart tissue right under that inner lining. So right here. And that's the first area of the heart to die because it's the farthest away from the vessel. So it's the most at risk. And then if you still don't have any reperfusion, you're still not getting any oxygen, the cells closer and closer are going to die. And if it goes through the full thickness of the heart wall, we call that a transmural heart attack or transmural MI. So it always follows a subendocardium and then it increases. And a transmural infarct will occur if you have about 3 to 6 hours of no oxygen. So even after 20 minutes, you're going to start to get irreversible injury. Some of your cells are starting to die. But it's still worth trying to get that person reperfused. Reperfusion means opening up the vessel to get more blood flow through because you can prevent it from going from a subendocardial into a full transmural heart attack. And you can imagine thinking about the function. If you stop a heart attack here, if you stop a heart attack when it's just in this area, you still have all this functioning myocardium here. That heart can still contract and still do its job pretty well. But when you have a transmural infarct, that whole part of the wall is now lost and can't contract. It'll be replaced with scar tissue. All right, this is just trying to bring it back to things you've already learned. So remember at the beginning of the class when we were talking about cell injury and cell death, we looked at this image and you saw an old scar here. And we were talking about the microscopic, the histology that you would see. So first of all, the mechanism of cell injury and death, we just talked about that, the loss of ATP. That's going to cause changes in calcium channels. Now your calcium channels can't work. Eventually your cells are going to swell, membrane dysfunction, and the cells will undergo irreversible injury. But I wanted to bring this back so that we can go through the microscopic morphology a little bit. What type of cell death are these myocytes going to undergo with heart attack? First of all, necrosis or apoptosis? Necrosis. What kind of necrosis? Coagulative necrosis, right. So grossly, here's another example of a transmural infarct. You can see this white is scar tissue. You don't actually see scar tissue grossly until a couple weeks afterwards. And that's because immediately afterwards, there's a lot of changes going on histologically, but the white is the scar tissue, and you don't get that scar tissue replacement until several weeks after the heart attack. So what would you see right away? So the first thing you're going to see is contraction band necrosis. And here, which this is a form of coagulative necrosis. The contraction band refers to the patterns that you see because, as I said, without ATP, the actin and myosin is held in contraction. So the myocyte is held into a contracted state. And these contraction bands, which you can kind of see here, here's another one up here, are demonstrating that. Other than that, you don't see many changes with coagulative necrosis right away. Basically, the tissue is held just in place. It's almost fixed. And for those of you who have worked in a lab and you know that when you do histology, you fix tissue with alcohol. Alcohol holds things in place. You can think of it because of the lactic acid production and eventually that acid is holding it in place. So fixing the tissue in a normal. But you see the myocytes. Now, this is 1 day after a heart attack. And you'll start to see, so you still see evidence of contraction band necrosis. Here are those contraction bands in the myocytes. But now you start to see inflammatory cells come in. And these are going to be neutrophils and macrophages. But especially early on, it's a lot of neutrophils. And they're coming in to start breaking down the tissue. So there's damage, and they need to get rid of that damaged tissue. So they dump a lot of hydrolytic enzymes, and they start to break down all of these cells. 3 to 4 days, you see you've got even more inflammatory cells coming in now. And you can even kind of see in this image, like this is a polymorphonuclear cell. So you can see that these are neutrophils and macrophages. So their job is to break down the dead tissue and eat it up. Now, this is about 2 weeks after an MI, right here. Most of these cells are actually macrophages. You can think of this as we've had our acute inflammation, we've kind of broken down the tissue. And remember that macrophages play a really important role in the wound repair process. So their job now is to recruit fibroblasts to start secreting growth factors, to make granulation tissue, to try to replace all of this dead tissue. Heart is permanent tissue. Your myocytes can't replicate. And so the job of the wound repair in the heart is to replace it with something. And the only thing that can be replaced it with is scar. So you have macrophages and fibroblasts coming in to repair by scar formation. And then after about 2 months, that's when your scar is fully formed. So these cells that we're looking at a couple weeks after MI, they're secreting extracellular matrix proteins like crazy. They're secreting growth factors. They're bringing in new blood vessels to support that fibroblast and macrophage activity. That's that angiogenesis with granulation tissue. But mostly what they're doing is producing extracellular matrix. And then by 2 months, this is all extracellular matrix in here. And some of these little pink dots are actually, this is a different stain, that's why it looks a little bit different. But these little pink dots are probably fibroblasts. Remember that after you have scar formation, you go through a process of remodeling, and the fibroblasts, they can secrete MMPs and other things to help that remodeling process. So mostly all the wavy pink stuff here is collagen fibers. So I'm not going to go too much into the management of acute MI. That's more, it's not really pathology. I just think it's really interesting. But most important is rapid reperfusion. And I want to just show you this image here. This is a coronary angiogram. So they're actually able to look at, they put dye into the blood vessels, and then they do successive x-rays watching the flow of that dye as it goes through the coronary vessels. And so here is probably the left anterior descending, because that's the most commonly blocked artery. And maybe this is the left circumflex branching off there. You don't have to know the vessels of the heart for this class. But look here, as this left anterior descending is coming down, it just suddenly stops. Blood flow stops. So that's where your blockage is. And then they put in a stent in that area, and then after the stent was put in, and a stent is like a little metal wire mesh. So they put it in, open it up, and now it holds the artery open. It kind of squishes the plaque out of the way, and blood can flow down there. So that's reperfusion. Yes?
Would there be a risk of rupture if you put the stent in too quickly, or was that my impression on it?
A risk of rupture of the coronary vessel or of the heart?
Right of the coronary vessel, right when you open up.
Yeah, I think that there probably would, especially if it's an unstable plaque or a plaque that has made that wall very thin. But it's considered extremely safe. I think that the people at Gore and other places that make stents have done a very good job of making it self-inflate at just the right pressure to avoid that rupture. But I'm sure early on in the research phase, there was a lot of risk of rupture from opening the stent. So what are some complications of a heart attack? Arrhythmias, I've already mentioned. So arrhythmias can happen for several reasons. Ischemia itself can cause arrhythmia. So if you have ischemia that's leading to a heart attack, that ischemia can also cause problems with the electrical system of the heart. But oftentimes what happens is as you generate scar tissue around the myocardium or around the myocytes, you're changing the electrical properties. They can no longer, usually the action potential is conducted from one myocyte to the next, and so you have this, they basically coordinate and you contract from the top of the ventricle down to the bottom of the ventricle to push it all out. And so the arrhythmia can happen because of the loss of myocytes from ischemia. Of course, the biggest problem is contractile dysfunction. Scar tissue does not contract. Dead myocytes do not contract. So you've lost that contractility. You're going to decrease stroke volume. You're going to decrease cardiac output. There is a risk of myocardial rupture, especially in the remodeling phase. Before that thick scar is formed, when the tissue is still kind of loose, the wall can be very thin and very not very strong. And so there's a risk of rupturing through the wall of the heart. That risk is biggest several days to a couple weeks after heart attack. By 3 weeks or so after the heart attack, if you haven't had a major rupture, you're unlikely to. I've already mentioned mural thrombus. So one heart attack can lead to the risk for the next heart attack. And then progressive heart failure. So that's probably the biggest thing. This is related to contractile dysfunction, is that you can't generate as much force anymore. And so the heart has to compensate for that. So we're going to talk about compensation in just a second with heart failure. But those are the major complications. Questions? Yes?
In the picture, is that myocardial rupture?
This picture is showing you myocardial rupture, yes. So this, you're looking at the heart from the outside. So the heart is surrounded by a lot of fat on the outside. And this is the left ventricle of the heart. The right ventricle is up here. This is the left ventricle of the heart right here. And you can see that it's just the wall has busted open. So that causes sudden cardiac death. You suddenly, all of your blood is going out into the pericardial sac. And you get, even with a small rupture, as blood leaks into the pericardial sac does not expand. It's very limited in its expansion. It can't expand beyond the normal heart contraction. And so you get cardiac tamponade, which means that the heart can't move. It's basically totally constricted within there. All right, I think we have a few minutes to do heart failure. You guys, you're okay? You're with me? Okay. So heart failure is basically reduction in cardiac output so that you can no longer meet the metabolic needs of the body. So if you understand what the heart does, it pumps blood to meet the metabolic needs of the family, you know what heart failure is. It's just the failure to do that. And we divide heart failure into systolic and diastolic, although this is a little bit of an arbitrary distinction because in most people, you have some degree of both. So remember, systole is when the heart is contracting. So systolic heart failure is basically a loss of contractility. Whereas diastole is when the heart is relaxing. So diastolic heart failure is an inability to fully relax. And then the other way we talk about heart failure is forward failure versus backward failure. Forward failure leads to backward failure. So again, this is kind of an arbitrary distinction, but forward failure means you can't get enough blood out of the heart. which is what causes heart failure. Heart failure is the inability to get enough blood out of the heart to the rest of the body. So that we call forward failure, and that's only to distinguish it from backward failure, which means if the blood isn't leaving the heart, it's not getting pumped out, it backs up. So you get that if you don't pump that blood out, your afterload, right? So you haven't pumped all of the blood out, afterload is increased. That's going to increase the pressure backwards from there. So if we're talking about the left side of the heart, you're not pumping the blood out, the pressure is going to increase in the left ventricle, left atrium, and then backwards into the pulmonary vasculature. So we get chest congestion, and that's backward failure. If it's the right side of the heart that's failing, then that backed up pressure is leading to increased pressure in the right atrium and then into the inferior vena cava, and you actually experience that as portal congestion or liver congestion because the IVC comes out of a lot of the blood from the portal veins come directly into the IVC, so that increased pressure is biggest and most felt by the liver. So when you're reviewing this, get out your old anatomy book and look at the anatomy of the heart and the vessels so that you can see where backward failure is going to manifest for both the left side and the right side. So backward failure is basically congestion. So oftentimes people will call it congestive heart failure because congestion, whether it's in the liver or in the lungs, is almost always seen with heart failure. So forward failure leads to backward failure. So the biggest and most important distinction with heart failure is which side of the heart are we talking about? What do you think is the primary cause of left-sided heart failure? Close, but yeah? Right side. So that's a really good point. Because the biggest cause of right-sided heart failure is left heart failure. But the reverse is not true. And so you really have to think about the anatomy of the heart to understand this. So if we think about the heart as this four-chamber system, right atrium, right ventricle, left atrium, left ventricle. So the blood is going to come in from the body to the right atrium, to the right ventricle. The right ventricle is going to pump it out to the lungs. From the lungs, it's going to come into the right atrium and then the left atrium. The left ventricle is then going to pump it out to the body. So all that's between the left and the right side of the heart are the lungs. And so if you think about what happens with the left ventricle, let's say that the left side of the heart is failing, the left ventricle is not able to pump the blood out of the heart anymore for whatever reason, that pressure is going to build up in the lungs. So the blood's not going this way, so we have increased pressure in the left atrium. That is going to go backwards, so that increased pressure is going to happen in the lungs. And so the right ventricle is now having to pump harder against the increased pressure in the lungs. The lungs are a small closed circuit. However, if we think about it with the right side of the heart, let's say the right ventricle isn't able to push blood forward anymore. So you have decreased blood to the lungs. That's bad. You're not getting oxygenation. Decreased blood is going to come to the left side of the heart. Therefore, decreased blood is going to go out to the body. So we still have heart failure, still not able to generate enough cardiac output to meet the needs of the body. But where that pressure gets built up is it starts to build up in the right ventricle, and then it's going to build up in the body. Now, the body is a much, much bigger system. So as the pressure builds up in the body, it's going to build up first in the vena cava and then in the liver. It would have to really build up throughout the whole entire body before it's felt again by the left side of the heart. Does that make sense? So that's why, because the lungs are a small closed loop connecting the left and the right side, left-sided heart failure leads to right-sided heart failure, but right-sided heart failure does not lead to left-sided heart failure. However, indirectly, it can, in that increased hypertension, increased blood pressure is the biggest cause of left-sided failure. So whatever is increasing systemic vascular resistance, it can be atherosclerosis, it can be increased volume, high blood pressure with just increased volume, or kidney failure. We're going to learn about that when we get further on. So kidney problems lead to hypertension. And that hypertension means increased pressure that the heart has to pump against. So that's the biggest cause of left-sided heart failure. You can also have aortic stenosis. So that's hardening of the aortic valve. Remember, the left ventricle is pumping blood through the aortic valve. So if that valve is stuck shut, you have increased pressure in the left ventricle. So clinically, I've already kind of mentioned this, but how is left-sided heart failure manifested? The most important symptom is chest congestion. So again, the pressure builds up on the left side of the heart, and therefore it's going to build up in the pulmonary vessels. So the pulmonary veins are going to have increased pressure. As those pulmonary veins have increased pressure, the pressure in the capillaries in the lungs increases. When you have increased hydrostatic pressure in the vessels, they're going to leak. Remember that you have to maintain both osmotic and hydrostatic pressure. So left-sided heart failure causes increased hydrostatic pressure in the capillaries, which causes fluid to leak into the interstitium. And so that's going in the lungs, that actually ends up leaking into the alveoli because you don't have a lot of other extracellular tissue around. So you get fluid in the alveoli. People with right or left-sided heart failure cough a lot. They often have trouble sleeping flat because the blood pools in their lungs and then they can't breathe very well. And so they'll wake up and gasping for breath. So chest congestion is the biggest one. For the right heart, the biggest clinical manifestation is liver congestion. And this will be felt, you can feel actually a swollen liver, and people may have a little bit of abdominal pain associated with that liver swelling. You want to do compensation? It's really fun. No, we don't have time, sorry. Okay, have a wonderful spring break. I hope to see you all refreshed and excited a week from Tuesday.